the thyroid symposium, we have got two eminent speakers. Thyroid disorders the commonest endocrine problem in our Myanmar. So the lectures given by our speakers will give their insights to management of these thyroid disorders and will highlight the advancements of the management strategies. And I will introduce the first speaker. Each speaker will get 25 minutes to present their talk. And at the end of the two speakers, we have the Q&A section. The first speaker is Dr. 𝗵𝗆𝗆 Vivien. She is well known to our Myanmar endocrinologists and Myanmar physicians. She has been here for several times for her talk. And she is an endocrinologist practicing at the Gleneagles Medical Center, Singapore, graduate of the National University of Singapore, and hold the MRCP from Waralee College of Physicians, UK. Also, the Master in Internal Medicine and Advanced Specialist Training in Endocrinology from Singapore. She is an Executive Committee member of the ISC and Treasurer of 𝗔𝗵𝘆𝗀𝗻 Society, Singapore. She has performed as the past president of the ASEAN IFAS and EMSS, and also the editorial board member in JCEM case reports. She has been the chairperson. She is the chairperson of the Education Working Group of the ISC and has been the chairperson of ISP IFAS AOCE, held in 2022 and very successful, and chairperson of the 7th Mayo course, and she gained the 𝗙𝗾𝗰𝗲𝗀𝗧𝗏 Award in Singapore 2014. And without much ado, I would like to invite Dr. Vivien. It's your floor, Vivien, please.
Now, without further ado, thank you for chairpersons for introducing me and the kind introductions. Thank you very much for Prof. Coco and his team for asking me to give this very practical talk. Now, my only regret that I can't be there personally in Myanmar to renew the bonds of friendship with the wonderful endocrinologist over there. And I can only console myself with showing myself this picture of a gun, which I took in 2019 in May. Now, without further ado, this is my financial disclosures, which is none for the purposes of this talk. So when I think about phase of hyperthyroidism, I think about phases. So who is this? This is the famous face of the Afghan girl, and she was the face of National Geographic in 1984. Now, thereafter, it took her a very long time for us to find who she was, and that is her in 2022. Now, when we talk about phase then in hyperthyroidism, what else then to talk about than this, that typical phase, lid retraction, ectodermal chemosis, erythema, asymmetry of the pupils, most likely because of muscular involvement, the muscular involvement of the eye, and therefore this is the phase of Graves' disease. Now, so therefore, my talk will cover what is thyrotoxicosis hyperthyroidism, different causes of it, focusing very practically on Graves', the factors that affect choice of treatment modality, factors that affect drug choice, and then touching on other causes. So some requisite facts that we all must know. So thyrotoxicosis depends on which survey you look at, about 1% of the global population. Now, what is hyperthyroidism and what is thyrotoxicosis? Now, hyperthyroidism is too much thyroid hormones produced and secreted by the thyroid gland, as opposed to thyrotoxicosis, which is too much thyroid hormones in general, and that's not necessarily due to high production for the thyroid gland. So this is the table that I took off of the ATA, the Thyroid 2016 guidelines, and there they were talking about causes of thyrotoxicosis and very appropriately putting it into those which are associated with normal or elevated uptake with radioactive iodine in the neck, which means these are hyperthyroidism. Good to have that concept. And this is thyrotoxicosis. So hyperthyroidism production, overproduction, and secretion by the thyroid gland. So our Graves' disease, toxic adenoma, MNG, TSH producing pituitary adenomas, they are here. As against thyrotoxicosis, where there's no uptake in the thyroid gland, even neck, because it is not producing there, and that is not the cause. And now we see a lot of immune checkpoint mediators since 2016, the time of publications, to now, which give rise to a lot of thyrotoxicosis. So for this talk, I am going to focus mainly on hyperthyroidism. So with that, I'm going to give you the case of Miss ABC. She's 42 years old, moderate hyperthyroid symptoms, does not smoke cigarettes, completed pregnancy, diffuse goiter, pulse rate tachycardic, eye examination normal. Laboratory results show a T4, which is about 2 times upper limit of normal, and TSH completely suppressed. The question then now is, what does this lady have? Now, statistically, you're going to know what she has really. But if I show you this, okay, then I show you this, the diagnosis would be made, this is grave, especially if I gave you this, but this is less than 1%. This is pre-tibial mixed edema, which is pathognomonic of Graves' disease. Now, if I didn't have that, and I gave you this, I'm lucky to have an ultrasound in my clinic, and if I see this diffuse disease, hypoechoic, and a little bit heterogeneous there, and then I show you this. And this is thyroid inferno, very vascular, again, characteristic of Graves' disease. So all this ties in. Now, if I don't have that, and a lot of times we would have to order a TRAB, a TSH receptor antibody. And in 99% of the time, this is Graves' disease is positive. But if it's negative, what do we do? Well, you can do a thyroid-stimulated immunoglobulin. It depends on the region and the facilities that you have there, or you do a thyroid uptake scan, because there can be a small percentage of patients who are TRAB negative Graves' disease, and you can see on the thyroid uptake scan that great uptake there, and so this in the combination and in this context is Graves' disease. So the cause then for this patient is Graves' disease. Well, my next question then is, what is your treatment of choice? And so here are the 3 treatments: medication, antithyroid drugs, radioactive iodine, or surgery. What are the factors then affect choice of treatment modality? Well, we have occurrence of ophthalmopathy, that development or worsening of ophthalmopathy after treatment of Graves' disease. So this was so a lot of this was done a while ago. It's good to see all the principles and all the concepts and all these studies coming in. So this prospective study is more studies. With the group 1, it was medical therapy against surgical therapy, seeing about the development or worsening of ophthalmopathy, and there was no difference in the 2 groups. In group 2, they had a medical against surgery, against radioactive iodine. Again, no difference in the medical or surgical group, but certainly you see compared with the medical group, radioactive iodine was 3 times that of risk of developing or increasing or worsening ophthalmopathy. Now then, this was a randomized controlled trial in 2000s, a follow-up of 4 years. And they found that if you had pre-existing thyroid disease, there might not be any worsening of the ophthalmopathy, but the new development definitely was more in radioactive iodine compared to medical treatment. And if you looked at smokers against non-smokers, regardless of which modality, there would be an increased risk of worsening or development of thyroid eye disease. What about looking at risk of relapse? We looked at thyroid eye. Now, one factor would be risk of relapse, and this was a meta-analysis of 8 studies comparing various treatment strategies, and one of them was radioactive iodine 7 to 12 millicurie. And over here, with anti-thyroid drugs, there's about 52% of relapse, radioactive iodine 15 as against 10% for surgery. Now, depends So depending on what is the dosage used for radioactive iodine, 7 and 12 is looking at this. But there is a higher cure rate or remission rate and a lower relapse rate if the dose of radioactive iodine is high. I'll talk more about that later when I give you examples. Now, this was an interesting report from Hong Kong's retrospective cohort of Graves' disease, initiating first-line treatment. And they were comparing between antithyroid against radioactive iodine against thyroidectomy, median follow-up of 90 months, 6,000 over patients from a Hong Kong center. And this was published in the Annals of Surgery. And this, we see about 75% relapse for antithyroid drug, medium time to relapse 21 months. Radioactive iodine, 19%, medium time relapse, 80. Surgery, 2.41%, medium time to relapse, 82. And this is very interesting to me to see what's the hazard ratio of other things which are not typically studied for against the three, compared for the three different modalities. And this is all-cause mortality, cardiovascular disease, AF, psychological disease, diabetes, and hypertension. And if you look at surgery versus antithyroid medication, the hazard ratio is much lower. It lowers the risk against antithyroid medication. Same thing against radioactive iodine. Now, then they compared radioactive iodine against thyroid and antithyroid drugs, and you can see that it still connotes a lower risk for the first four, but not for diabetes and not for hypertension. Then this was a cost analysis study. And if you can see, this is surgery, this is radioactive iodine, and this is antithyroid drugs. And of course, in the first year, the thyroid surgery was much more expensive. But as the time progressed over 10 years, you can see that actually thyroid surgery seems to be more cost effective than that of antithyroid drugs and radioactive iodine. So now, what about the size of the thyroid? That would be another factor as well. So this lady, she was 29 years old, presented 3T for 100, huge thyroid goiter. And I needed, at that time, my ultrasound needed to do it this way, to put two together just to get the right look, which was 23 mils. So in total, it's 40 mils on the right. She went for radioactive iodine. She was given 29 millicuries. So 29 millicuries after 6 months, 9.6 mils on the right, 4 mils on the left. And I changed the ultrasound machine. So if you look here, left is 1.86 mils, right is 3.9 mils. This is 1 year later, and this is at 2 years later with a total thyroid volume of about 4 mils. So 1/10 of that of the original thyroid volume. The fourth thing to think about is childbearing age. Do they want pregnancy? When are they wanting pregnancy? And why is this important? Because let's take a look at anti-thyroid drug use during pregnancy and the risk of birth defects in this offspring. If you take a look at methimazole and 𝗵𝗵𝘆𝗃, what's the difference? Methimazole, 𝗵𝗵𝘆𝗃 is a prodrug. It is converted to methimazole, and then it has effect as against PTU. So you see the risk of congenital or birth defect is favoring control, as in there is a 1.28 risk involved in terms of methimazole or 𝗵𝗵𝘆𝗃, and if you look at PTU, it's 1.16. Now, if you look then, it is still beneficial, and you still should give if this is the choice, because PTU exposures against pregnancy, against untreated women with hyperthyroidism, it of course favors that of treatment as against not treating and allowing the person to be uncontrolled hyperthyroid during pregnancy. Now, whether then another consideration is whether definitive treatment will be beneficial. And these are the possible situations we definitely want not to have a relapse. And one of them is cardiac consequences such as AF and heart failure, liver consequences, impending liver failure, and drug allergies, multiple drug allergies. So difficulty to control, remitting or relapsing despite compliance, or sometimes even because the patient is non-compliant. This is something to consider. So back to this lady then. So with all that factors to think about, what would your choice be? And the many phases of hyperthyroidism also shows many phases of treatment. People have different preference, not just physicians, but also that of patients. So this is a very nice little survey. 2023, there were several surveys through the years. This is the third one. The one before that was in 2011, 10 years ago. So this is the international survey to evaluate the current practices in managing Graves' disease and compare to previous surveys. It was a global online survey involving 1,250 respondents from 85 different countries. So they gave them index case, and interestingly, I gave you that index case, that 42-year-old lady, and then they gave them other scenarios at the same time. And so this is the gender of those people who responded. Males are 40%, and in the region for Asia, since we are in Asia now, a quarter of them are for Asia. Vast majority of them are adult endocrinologists. This was to show the relative importance of factors that would impact the selection of the primary therapy in uncomplicated Graves' disease. And so the responders would rank 4 possibilities by level of importance, from most important to least important. And you can see the 4 things that they're thinking about: hope for remission, avoid hypothyroidism, avoid radiation, avoid worsening thyroid eye disease. And it seems that the most important was that of hope for a remission. And then next was that of avoid hypothyroidism. So then what is the choice of therapy in different variations of the case? So the index case, which I gave you, vast majority chose anti-thyroid medications. In fact, if you look across all of them, it's anti-thyroid medications. Now this was throwing in things, 2 things. One was the smoker, and number 2, moderate to severe Graves' eye disease. And what you see now, the surgery rate has gone down, the preference for surgery. And there was still radioactive iodine, most likely in the moderate cases in which they put it with prophylactic steroid. Then in pregnancy, again, surgery factored in here as against RAI. So what happens in older age? RAI seems to be more than in an index case or the simple, non-complicated case. And finally, what happens to relapse? And in the relapse situation, it's interesting now, a key change that it is still anti-thyroid drugs in the majority, whereas radioactive iodine is the minority, 37%. And this is the changes in trend of treatment modality selection over that 1 decade. So in uncomplicated Graves' disease, you see from this, which was mainly based in America, where the predominance of radioactive iodine has gone to have a key change now, such that in 2023, 91% would choose medication first, and hardly anyone would choose surgery. And then what about thyroid eye disease? You can see then the increment of surgery comes in, whereas radioactive iodine is much, much less, and pre-pregnancy at the same time. And this is the coding down to Asia to show what we have selected. And vast majority, 95%, would choose a thyroid drug to start with, and 5% would do radioactive iodine. So now the decision, let's say, because we're based in Asia and looking at all the data, it seems that the vast majority would choose an anti-thyroid drug. So our decision is to start this medication. Then the question next is which drug and how long? So this is a meta-analysis with regards to PTU and MMI in the treatment of hyperthyroidism. So the odds of liver injury was higher in the PTU group than in the methimazole group, odds ratio of about 2.4. Odds of elevated transaminitis was much higher in the PTU group, and it's 3.96. But there was no significant between group differences found in the odds of elevated bilirubin, agranulocytosis, rash and urticaria, and incidence of other adverse events or in children. Now, what about this odds of birth defects during the first trimester of pregnancy was higher in the methimazole-carimazole group than in the PTU group with 1.29. Now, let's look at the percentage of relapse. Now we talk about duration of treatment. And these were the ones when, why do we keep thinking about 18 months? Okay, here is where it was, the early 1990s and the 1999. So first they had, comparing this prospective study, 6 months against 18 months, and 18 months had a higher remission rate after 2 years. Okay, then this was another study which showed that, which compared then longer treatment duration, 18 months against 42 months. And they showed that there was a trend towards a lower relapse rate with a longer duration of therapy. Unfortunately, the data was small and it was non-statistically significant. Now, this is a very nice data from Korea, where they showed a retrospective multi-center cohort study, 908 newly diagnosed Graves' disease patients, and the relapse rate according to the anti-thyroid drug duration. If you look at this at 1 to 2 years, or 2 to 3 years, let's put at 2 to 3 years, that's quite a high relapse rate. And especially even after 6 years, there is still a 20% relapse rate. And the same study showed then what is the risk factors associated with relapse. One is age, a lower age, gender, male. 𝗧𝗵𝘆𝗿 in that study did not show to have a difference. Neither did grave orbitopathy, but certainly smoking. The duration of the thyroid treatment would be a higher duration, would have a higher, lower relapse rate. The higher the free T4 level had a higher relapse. Now, therefore, we take into consideration when we are deciding the drug and for how long, side effects, the convenience of dosing, wanting pregnancy or not. And in those with severe Graves' disease, there's a study which showed that methimazole is actually better than that of PTU, and at 30 milligrams per day, normalized free T4 in more patients than PTU 300 milligrams per day. And mind you, 30 milligrams per day can be done once a day. Or you want to do it, you can split it. But 300 milligrams per day, you are actually doing 500 milligrams 3 times a day. And it's a little bit bitter for PTU. So the latest survey in 2023 did not survey this, but the 2011 survey surveyed and showed that the majority of people actually use methimazole as against 𝗙𝗵𝘲𝗀 and then PTU. And the duration of anti-thyroid drugs, majority of people used 18 months, and next was then 12 months. So what happens then is we discussed already this, but now I wanted to hone in on this part which I did not show, which is one about persistence. And what is the definition of persistence? The TRAV, which is positive. And so in persistent diseases, what happens? And what was told, and this was the thing, is still anti-thyroid drug, which is a sea change now. Most would still go on with anti-thyroid drugs as against going on to surgery or radioactive iodine. So back to this patient then, I started on methimazole 20 milligrams, started beta blockers to block the sympathetic effects of the thyrotoxicosis and await for methimazole to work. And this was the original scan with a thyroid inferno, and this is after 6 months, a more Poisson-looking ultrasound. So then I would treat the target. This is the buzzword nowadays. What is treating the target? For my practice, I would do euthyroidism for 18 months and TRAP is normalized first. Then I will consider stopping and monitoring for relapse. And if you relapse, I will discuss with the patient now which to give now. Radioactive iodine, surgery, or continuum medicines. And it will be likely medicines if it is controlled on a low dose, if the patient is compliant, if this is the patient's preference, and there are nothing that came out that made me want to think I should go for definitive therapy. So let's say I move on next to this patient with Madam DEF, 81 years old, complained of loss of appetite, tired all the time, hardly can hold up her chopsticks. This is for free T4, which is 55, TSH is 4.3. I'm going to pause here and think about this. What is this? This is a thyrotoxic, definitely a thyrotoxicosis. It's this hyperthyroidism. So first off, if you take a look at the free, if a T4 and a T3 goes up with the primary thyroid gland problem, the first thing that moves is the TSH exponentially. It goes up very sensitive. It's the first thing that moves. So it will go down. The minute the free T3 and free T4 is on upper end or even over the limit, you would see complete suppression. But this lady did not have that. She had a TSH which is within the normal range and in fact on the high end of normal. And so this is an inappropriately normal TSH for a primary thyroid disease. So what did she have? Well, she has a TSH producing adenomas. They're very rare, but you need to be aware in this many phases of presentation of hyperthyroidism, and you think about this because the TSH is inappropriately normal or if the TSH is high. The other alternative could be thyroid resistance, but that will be beyond the scope of this discussion. So another thing to show is the various phases of presentation. One of them we must be aware of because we are all aging. The presentation of thyrotoxicosis in elderly might be different. And for these group of people, the sympathetic system is actually it's more dumbed down. So you don't see classical sympathetic symptoms as in tachycardia, tremors, hyperactive reflexes, increased sweating, diarrhea, or heat intolerance. All that is much less and less frequent than that of a young patient. Whereas what you see are more subtle symptoms, such as apathy, such as anorexia, and you have perhaps even constipation. So you must be on confusion. So be on high aware and high alert for these patients, and that they might be having a thyrotoxicosis problem. Now, this patient is Miss Nancy. She's 65 years old. She presented with osteoporosis. Endocrine, wonderful. Endocrine is osteoporosis, which is under me, and it's also thyrotoxicosis. And you know, one of the reasons why you have osteoporosis, secondary cause, would be that of hyperthyroidism. So her TSH is less than 0.005, and the PT4 was slightly above normal. TRAB is negative. I just want to show quickly this thing. Here we have many nodules. Again, I'm very lucky to have an ultrasound in my room, in my clinic. So my patient just popped a huge nodule here. And what do we do? In the interest of time, I won't show you the left one. I sent her for a thyroid scan, and there we go. This is multinodular goiter. We have a discussion then. What are the options? Same thing, medication. But if you give medication, there is no remission here. It's an autonomous projection you give forever. Radioactive iodine, good choice, possible choice, because you drink it, it's taken up by the toxic MNG, and then it strings the nodules as well as causes remission. And surgery, that's also an option. Now, this is another patient, and she had huge adenoma, and it was 19.26 mils, again presenting with mild hyperthyroidism, and this was a toxic adenoma. And in this case, I would send for radioactive iodine. This is either, again, it's the same option, you take medicine for the rest of your life, or that 19.26 mils can be sent for surgery or radioactive iodine, which would then shrink the adenoma and at the same time cause a remission hook. Now, this patient then had multiple nodules at the same time, and this was interesting because you see that small little nodule here, and that the huge nodule was actually not the one which is hyperfunctioning, but it is actually the small nodule which it is. No, so for this patient, even though it was small, even though it was mild hyperthyroidism, she required 10 milligrams of methimazole in order to keep her TSH normal. So in this patient then, again, the discussion to be had are the three options. You continue medicine, and that would then give you a euthyroidism. But then the nodules have to be taken care of because it's not thyroid, because it's not a functioning dominant nodule. It might have a discussion in which, why don't we go for surgery then? So pushing more towards surgery to effect that you're removing that toxic adenoma, that small one, and also removing the huge one, which is 3 centimeters. So back, and one final case here. Now his PM day, he came panicking. I'm sneaking this in now. The PT4 is 50, so it's definitely thyrotoxic. And he was panicking because his ultrasound was done and he told he had a large and ugly tumors in his thyroid. And this is how his ultrasound looked like. In retrospect, he did have some thyrotoxic symptoms. Now, what happens here is that, let me show you the ultrasound here, which I did. Okay, you can look on the 2D ultrasound, looks horrible, looks like a tumor. But then if you look at this carefully, this is the right thing. The whole lobe is involved with the history like this. This is subacute thyroiditis. So actually, I'm sneaking this in because this is not hyperthyroidism. But it's interesting to show that these are many phases of TSH suppression and PT4, which is high. And sometimes you can be fooled by what is presented because the technician is the one who reads the ultrasound and who shows the ultrasound. And when the pathologist gets it, when the radiologist get it, they might just see this and they can't not call it a tumor. But if you see it yourself, you actually see with the history this is subacute thyroiditis. When you send for thyroid uptake, then there's nothing there. So what happens is that you happen to get it at the thyroid toxic phase where it's released. There's no projection. There's only a release because there's an inflammation there. And it will then transition, and this is triphasic reaction. It transitions to normal, and then it might go hypothyroid, and then it goes back to normality in the vast majority of patients. You beta block here to treat, and then over here, you might, depending on how bad it is and how long it is, give thyroid hormone replacement, and then after that, you take it off. So this is expectant monitoring. Don't need to do anything else. So in conclusion, we talked about what hyperthyroidism is, which is overproduction from the thyroid hormone and increasing it out. We talked mainly on Graves' disease, the factors to consider when deciding treatment modality, various scenarios and how that affects choices. And if we are treating with medications, the factors affecting drug choice and duration. We talked about also atypical presentation in elderly, in a patient where a TSH inappropriately not suppressed or inappropriately normal when the free T4 is high. So think about then central in terms of hyperthyroidism. And we gave you smatterings of different causes of hyperthyroidism, adenoma, toxic multinodular goiters, and discussing the treatment options. So thank you very much. If I had no time for questions, you could definitely email me for that. Thank you.
Thank you, Dr. Vivien, for your comprehensive presentations. And the second speaker is Dr. Waralee Chatchomchuan from Thailand. I would like to introduce Dr. Waralee. She is a board-certified endocrinologist with specialized expertise in thyroid disorders. She completed her medical degree with second-class honors and underwent fellowship training in endocrinology and metabolism at Chulalongkorn University. She got master's degree of science in medicine from same university and postgraduate diploma in obesity and weight management from University of South Wales, UK. She also has short course training in high-intensity focused ultrasound for thyroid nodules treatment from Queen Mary Hospital, Hong Kong. She currently leads multidisciplinary thyroid care team at her hospital, 𝗦𝗫𝗇𝗏 Hospital, which was the first in Thailand to receive disease-specific accreditation for thyroid care from Healthcare Accreditation Institute. She is also a pioneer in development of thermal ablation program for thyroid nodules in her institution. Her clinical and research interests include thyroid diseases, thyroid nodule management, innovative therapies, and multidisciplinary care models. She has published in national and international journals and contributed to the development of thyroid care through her clinical and academic experience. So, we are honored to have Dr. Waralee with us today. She will present a title of Advances in Diagnosis and Treatment of Thyroid Nodules. So, without further delay, please join me in welcoming Dr. Waralee to the stage, please.
Thank you very much for the kind introduction, and thank you for the MMDA for inviting me today. Okay, so I'm really pleased to share with you some updated on the recent advance of the diagnosis and treatment of thyroid nodule. So I have no disclosure. Here is the outline of my presentation. I will begin with the thyroid risk classification, followed by the axillary ultrasound techniques and the AI tools, as we all talk about this all day, and for the molecular testing. And for the advanced treatment sections, I will discuss about thyroid ablation and transoral thyroidectomy. Okay, so we meet Miss Elsa. She is just 40 years old with a thyroid nodule. During checkup, she has no family cancer, family history of thyroid cancer, and we can see that on her ultrasound there are two nodules that look like this. Okay, the both nodules are hypoechoic with small calcification on the right nodule. So the question is, what should be done next? I would like to review the management of the thyroid nodules. The main goal is to detect the malignancy. So we usually start with ultrasound, then classify the risk of malignancy using either the ATA system or the thyroid classifications. And here is a quick review. The current ATA guideline from 2015 uses ultrasound pattern to modify the estimated risk of malignancy and propose cut-off point for the fine needle aspiration. And finally, the ATA 2025 guideline for thyroid cancer was just published 2 days ago. They move forward to more individualized assessment and possibly de-escalations of unnecessary intervention. For example, for radioactive iodine use and the follow-up interval of the thyroglobulin. This time, the ATA has separated the thyroid nodule guideline and the cancer. So for the thyroid nodule, we will have to wait a bit longer, but I think we will see this guideline this year. And another, for the ACR thyroid, as I mentioned earlier, this is the difference from the ATA. It's a scoring-based system, not a pattern-based one. So we calculate the score, here are the thyroid category from 1 to 5, and the criteria for fine needle aspirations differ slightly compared to the ATA guideline, just a bit. And so what should we choose between the ATA guideline or the thyroid guideline? A cross-sectional study of 197 thyroid nodules in Philippines show that ACR thyroids appear to be more sensitive, while ATA classification more specific, but not that much. It's around 52% and 57%. So it's quite similar for both systems. And the systematic reviews compare 6 classification systems. We use the AACE, ACR thyroid, ATA, European thyroids, K-thyroids, and Quark thyroids. These reviews show that ACR thyroid has the highest sensitivities and ACR thyroid has the highest specificity overall. So back to Miss Elsa. Her left nodule is solid, hypoechoic, and has micro calcification. This is the ACR thyroid 5, while on the right nodule, actually right for me, the right nodule has no calcification, so it belongs to thyroid 4. She does not want to do the needle aspiration, and she asks if there are any other technique that may help. So I will come up with the European guideline 2023 that they are another auxiliary tools such as the Doppler imaging, elastography, and contrast-enhanced ultrasound. These two can help refine the risk classification. So we will see these auxiliary ultrasound tools. For the Doppler ultrasound, you will see this one, we will see the vascular pattern, and for the elastography, we will see the stiffness. And for the contrast-enhanced ultrasound, we will use the microbubble, is the contrast, and inject to the patient and see that the microbubble inside, when we do the ultrasound, see the perfusion. And here is a comparison of this technique. Among these 3, elastography has the highest accuracy. In Thailand, we do not have, we haven't had yet for the contrast-enhanced ultrasound widely available, so we prefer the Doppler imaging and elastography. So back to, and all this technique, limited value is heavily calcified or purely cystic nodule, and this technique is lack of cut-off point. That's why it's just another helper tool not in the standard guideline. And C, we back to Miss Elsa, and here is what we choose is the ultrasound elastography for her. And we will tell about the elastography just a bit. The ultrasound elastography is evaluated tissue elasticity, the stiffness. The more stiffness, the more malignant it will be. So they have two types of elastography, the strain elastography and the shear wave elastography. The strain one, as you can see, its output is the color map. But for the shear wave elastography, the output is a quantitative stiffness, measurement in kilopascal, so it's more like the fibro scan when we do for the liver. So it's just another different techniques. And here is an example image of the strain elastography. So back to Miss Elsa. You can see from the color scale at the right nodule is harder than the left. So eventually the fine needle aspiration confirmed the right nodule was malignant. Actually, the picture is quite the same, but when we do the elastography, it's totally different. So this might help in the future. And today we're talking a lot about AI in eye detection and diabetes. AI is also showing the promising in thyroid treatment. There are several promising techniques that use the AI to help classify the risk of malignancy. This is an example of one company. But for now, the remain supporting tools, we still need more evidence before they can be used routinely for the thyroid. So the next step after we do the classifications, let's move to the fine needle aspiration, and then we move to the Bethesda 2023 update and molecular testing. Here is the latest Bethesda system 2023. Right now it has been adapted to reduce ambiguous terms, so no more uncertification of follicular lesion undetermined significant or suspicious for follicular neoplasm. Right now we don't use this term anymore. And here is the risk of malignancy. It's changed a bit. So for the new Bethesda system, okay. The most important update is indeterminate nodule, where molecular testing is now suggested. And here are some commercial molecular tests available. As you can see, for the sensitivity and specificity, it's quite nice, around 80 to 90%, except from the 𝗏𝗏𝗧𝗏. It has low specificity, it's around 68%. So for the 𝗏𝗏𝗧𝗏, it should be just only the rule out result, not rule in. And for the price, actually I use for the government rate online, so it might be a bit higher in Myanmar. Yeah, but I quote this one in pounds. And here is the Asian data. So what should we do? It's the average range of indeterminate nodule, which is the Bethesda 3, 4, and 5. It's around 40% to 87%. So is it cost benefit to do the molecular testing as they recommend? For us in Thailand, we don't use this one because we can tell with the cytologist. Because for the AUS, if you tell the cytologists that they have the nuclear atypia or not, if they have the nuclear atypia, the risk of malignancy is quite high. But if it's AUS by others criteria, the risk of malignancy is lower by half. So we just talk to the pathologist. I think this one might fit for us. Okay, so let's move to the treatment sections. Here is the thyroid thermal ablation. For the thyroid ablation, actually it's any kind of procedure that can use heat, cold, microwave, chemical, or electricity to vaporize or to abrade the thyroid and the tumor. Right now we have the percutaneous ethanol injections. We have the rest. The full rest is for the thermal ablation. We use the radio frequency, laser, microwave, and high intensity focused ultrasound. And here is the comparison of the thyroid thermal ablation. For the radio frequency ablation, we use the ultrasound guide and we use the electrode pressed transcutaneously into the target lesion and use the thermal heat from the radio frequency. As the same for the laser thermal ablation, but we use another electrode like the optic fiber. And for the microwave too, but for the microwave, it uses the microwave applicator. But for the HIFU, this is another different technique because we use the ultrasound to focus. It's like to do what we so-called is the HIFU. So it's like when we try to make we look young. But it's a different technique. So it's point out that when we use the ultrasound to focus, it can generate the heat and can vaporize the thyroid cells. So the main utility, normally we right now do the solid and benign compression thyroid nodule. And for the thyroid malignancy, the evidence is upcoming. For the therapy durations, for radio frequency ablation and microwave ablation, it needs around half an hour, but for the HIFU, it needs around 1 hour. And for the volume reduction, as you can see, the radio frequency ablation and microwave is quite similar, whereas the laser thermal ablation is a bit low, and for the HIFU, I think it's not cost effective. And coming up with the cost, because the laser is not available in Thailand, we have just only radio frequency ablation and microwave ablation. It's around 60,000 baht. So I think it's better than to go on the surgery, which is around 3 times more. Okay, and here is our patient after the procedure, the HIFU. The best for the HIFU is there's no need for any electrode, so it's a scarless, because they use the ultrasound and it generates the heat inside. Right now you can see just only the redness on her neck. And so which method should we choose? The international multidisciplinary consensus states that the radio frequency is the most preferable for solid benign nodule. And for the cystic nodule, we still do the percutaneous external injections. There is evidence that using the ablation of small cancer and recurrent disease, but long-term data are still lacking. Even in the 2025 ATA guideline, they still mention this one, that there might be a role for the cancer who are less than 2 cents. This might be another technique that can be used instead of send the patient to go on the surgery, but we need the long-term data too. And the one concern after the ablation that I face, because when we put the heat inside the nodule will shrink and it's turned black. It's turned more hypoechoic and it's turned round. So when we see this one, we might misinterpret as it's turned malignant. And when we do the fine needle aspiration, the cell will, the result must be in the AUS because the cell is shrink. So the clinician must be careful in follow-up. Okay, so the next topic is the scarless surgery, known as the transoral endoscopic thyroidectomy vestibular approach, or 𝗧𝗏. In this technique, the incision is hidden in the mouth. This procedure, the surgeon makes small incision inside the lower lip and insert the cannula and special instruments. A working space is created under the CO2 gas inflations, and using the endoscopic visualization, the thyroid is carefully dissected and placed in a retrieving bag and then removed through the mouth incision. So if the thyroid gland is huge, it's hard to remove from the mouth. So here is come with the limitation. So the indication for the 𝗧𝗏, the patient need more about the cosmetic concerns, and thyroid should be less than 10 cents, and the dominant nodule or tumor should be less than 6 cents if benign or indeterminate pathology. But if it be TESDA 5 or suspicion or confirm the thyroid cancer, it should be less than 2 cents. Because the it comes with the contraindication, because ตัว preoperative recurrent laryngeal palsy is one that we should mention, and the lymph node metastasis. We cannot find the right room for this surgery. So if the patient have the thyroid cancer with the lymph node metastasis, we prefer the open surgery. And here is the outcome of the 𝗏𝗏𝗏. This is published on 2021, and we collect the case for around 400, and the success rate is around 99%. And as you can see, there has no permanent recurrent laryngeal nerve or permanent mental injury. And for the transient hypocalcemia and nerve injury, it's not that much. So I think it's the one is a safer way for patients to choose. And the complication of the 𝗏𝗏𝗏, the common thing is the seroma, the emphysematous, and the hematoma, and the mental nerve injury. But this is a rare complication because we are the referral hospital. So we refer the patient who undergone 𝗏𝗏𝗏 outside, and then we treat after. This one, as I can see. This is the patient that have the delayed cervical pneumatocyst. This is tracheal injury, and then when she cough or she do the Valsalva maneuver, the neck is bulging. Luckily, this patient is spontaneously resolved within 3 days without no need to reoperation. And the other one is even the 𝗏𝗏𝗏 is quite safe, but it still can harm the sympathetic ganglion and can cause the Horner syndrome. This patient have the Horner syndrome, and eventually this patient right now it's around 2 years follow-up, and she still be there. Okay, so here is my summary. The ACR thyroid has high sensitivity and specificity. For the ultrasound technique that may help, the elastography, the harder the nodule, the more likely it is malignant. For the AI tools, can assist in interpreting the ultrasound image. And molecular testing is useful but may not be cost-effective. And consult a cytopathologist regarding the AUS reporting with or without nuclear atypia. And for the treatment, thyroid thermal ablation, it can reduce volume of the benign nodules and may treat small malignant nodules. And the last one is endoscopic thyroidectomy, offer a scarless approach in the thyroid surgery. And for the last, I'm thank you for my team. Okay, and here is my email. If you have any question, feel free to contact me.
Thank you very much, Dr. Waralee, for your very informative and very comprehensive presentations. You mentioned about the diagnosis and treatment of the thyroid nodules. And regarding with the diagnosis, you highlight on the importance of ACR T-RAD score because of the very high sensitivity and specificity.
Yes.
And also you mentioned on the different types of diagnostic method, especially on the elastography. Yes. And the importance of elastography, and also you mentioned about the types of the different types of the elastography, and also application of the artificial intelligence in diagnosis. And second part of the presentation is the modernized therapeutic treatment option, especially using the ablation, different types of ablation of the thyroid nodule, especially TOEDVA, transoral endoscopic thyroidectomy vestibular approach. And so we learned a lot from your presentations, and we should be apply this information in daily practice because the modernized radio ablation therapy has many advantages. Especially, you mentioned in your presentation very minimally invasive no scar, and recovery time is very rapid. So thank you very much for your very informative presentations.
Dr. Waralee, please take the seat. So we have here the very informative topics from both speakers. So I think that the audience will have their many questions to ask. So this is a time for Q&A. Is Vivien still online?
Yes, I'm here.
Okay, right. So you can ask questions.
Thank you. Thank you, Dr. Vivien, Dr. Waralee, for very insightful informations and very illuminative talk about the thyroid diseases. Dr. Vivien, my question is for first Dr. Vivien Lim. Actually, we do commonly see the TRAP-positive thyroid eye diseases with completely normal thyroid function tests. Those cases have been referred to endocrinologists by ophthalmologists because those patients attended to ophthalmologists and then they said, go to the endocrinology for consultation. But thyroid function tests are absolutely normal. So we are a bit in the dilemma, what would we do next? So what is your response about those kind of diseases? Is it just wait and watch policy, or is it worthwhile to start anti-thyroid drugs because of antibody positive? That is my question. Thank you.
Okay, thank you. Okay, so with regards to that, I get the same problem as well. Now, if you look at the data, the thyroid eye disease may predate that of thyroid function test abnormalities. So that's one thing. What is the function? What is the use of an anti-thyroid drug? Two things. It works at the thyroid level to decrease the synthesis. And number two, it may, it's a bit controversial, it may do immunomodulatory, bring down the TRAB. But the problem that if you get this patient and the thyroid is normal, now we don't know why, it's still in debate as to why is it that it only attacks the eye. Is it because there's something sequestered there? The TRAB can even be negative even, and yet it confirms eye disease. So in that case, if I were to give anything, methimazole, 𝗑𝗵𝘆𝗄, this patient is going to give hypothyroidism. And then we might have an issue there because the drug isn't an immunosuppressant drug. The drug at the heart of it works at the thyroid primary level. So I wouldn't give these drugs. In fact, I would then look at all the new immunomodulators that are coming out for the thyroid disease, which then can work at that level. And there are a lot of drugs now in phase 2 studies, phase 3 studies, if I'm not wrong, 𝗏𝗏𝗏 is one of them. But again, we have no data, we have no real world use for that. But as of now, I wouldn't start an anti-thyroid drug for that.
Thank you, thank you. Actually, immunomodulators, we are also not very familiar to using for thyroid eye disease. So what about selenium? Selenium, is it worthwhile to use selenium for thyroid eye disease? Because there are some data about that selenium can reduce the thyroid antibody, TRAB. So what is your suggestion?
So I'm a practical person because at the heart of it, how many of us are selenium deficient? It is a trace element. So there is no harm, I guess, in giving selenium, but you think about it, at the heart of it, this is an autoimmune condition. In other words, the body does not recognize the thyroid or one of the antigens which is around. So that is the heart of the problem. How does selenium then bring down my autoimmunity? The only thing that can really do that is immune modulator. So with selenium, no harm, sure, you can give. But if you're having severe thyroid eye disease, moderate thyroid eye disease, I wouldn't play around with that alone. I would actually send it, it's a multidisciplinary thing. I'll send it to my friendly ophthalmologist and ask them to please have a look. And the first thing is still steroids. Why? Because immunomodulatory, anti-inflammation. So that would be what I would propose. Selenium, no harm, but well, if it's severe, I wouldn't wait.
Thank you, thank you. Depend on I got the message from you that depends on the stages of the thyroid eye disease. We better consider about the anti-inflammatory medications rather than selenium.
Yes, correct, absolutely, yes.
Any more questions? May I get the opportunity to ask Vivien again? If we have the pregnant lady with the hyperthyroidism, but they did not turn up their follow-up and suddenly come back with a pregnancy, and they are very toxic, thyrotoxic. And when we use PTU in the first trimester, so PTU, and the lady got very hepatotoxicity, severe hepatotoxicity. In that case, what we should do in that situation?
Okay, so at the end of the game, just being practical here, if I don't do anything, baby's probably not going to survive. You know, the risk, as the data has shown already, if you see there, PTU against untreated hyperthyroidism, already it favors PTU. Okay, so now patient comes in with PTU hepatotoxicity. I have no choice. I have to stop PTU. But then what about methimazole? What about 𝗑𝗵𝘆𝗶𝗂? We kind of have no choice. So then we move to that then instead. And in fact, it's a luxury to be able to change from 𝗑𝗵𝘆𝗶 or methimazole to PTU, and then to change back again. You know, that's a luxury, because most of people, you might not be able to do that depending on where you're practicing, which region of the world, what hospital you are in, or if you even have the availability of drugs. So because of that, we know that actually 50%, or depends on which survey data you look at, go to pregnancy with 𝗑𝗵𝘆𝗶 and methimazole. And I have patients who have accidentally got pregnant. They swear they're not going to get pregnant, but they accidentally got pregnant with methimazole and 𝗑𝗵𝘆𝗶. Then it's a discussion that we'll be having on that. And most of the time, they might stay on that. So for this lady, I would definitely change to methimazole, 𝗑𝗵𝘆𝗶. Please have a multidisciplinary, the ONG, beta blockers has to come in. Because at the heart of it is the sympathetic action that is the problem. So beta blockers blocks that of the effects of the excess thyroid hormones.
Thank you. Prof,
hello, Vivien, thank you very much for your very nice talk, as always. We come across a case, you know, the patient with like a 40 or 50 with atrial fibrillation, rather like quite a toxic. That lady got an allergic reaction, firstly with the methimazole, and then it changed to propionyl again, allergic again. So she allergic to 2 medications. So that time we increased the beta blockade, and she have to take the radioiodine treatment, which she need repeatedly, several doses. Only after quite a while, like about 2 or 3 months, she subsided. So that was a very difficult situation. Do you have such a problem before?
Oh yes, we have even people with common heart failure, liver failure. That's why one of the mentions I talked about definitive therapy was liver failure. So basically in this group of patients, when you're allergic and you are toxic already, you need to beta block, right? You beta block high doses, and you need to send them for a definitive therapy. Which definitive therapy then depends on the discussion with the patient. What if there's eye disease and that's severe? Then you cannot do radioactive iodine. You might even have to do total thyroidectomy. But it's the same way of dealing with it. As in you beta block, you might need steroids on board at the same time, and then you prep. If you're going total thyroidectomy, potassium iodide. If you are going for radioactive iodine, one part is that it depends on which part of the world, how much you are using. So in Singapore, I realized that they are using at a high dose, which I totally agree with. If you look at the other parts of the world, even in the studies, you're talking about 7 to 12. Then after you're talking about 18 millicuries. Now, the patient that I showed you was given 29 millicuries, 40 mils. When I send patient for radioactive iodine, I am telling the nuclear medicine doctor I want definitive treatment. They are not going to be wishy-washy on me. They are going to give definitive treatment. And depending on how they do it, they might not give a fixed dose. They might calculate the volume, sort of semi-quantitative approach and give. So those that I have sent, I have never seen them give lower than 22 millicuries. So mainly those which I send are because they have failed medical treatment. They're non-compliant. It's a huge goiter. I'm sending already, right? If not, most of us will just keep on medical therapy. So for this, give the higher doses. Because it's interesting that you mentioned that you needed multiple doses. When I give the higher doses, even at 1 month, some of my patients, I have shrinkage already. And they might already be not functioning. It's just that you are not seeing it because the free T4 is still hung up, because the half-life of free T4 is still high. But they actually might already have gone into thyroiditis phase, looking like a subacute thyroiditis on the ultrasound. And they are probably not producing already. And within 6 months, if you looked at what the picture I showed you for that lady who required high doses with 40 grams of thyroid, you see the shrinkage is quite a lot, even within 6 months already.
Thank you.
And by the way, she only needed 1 dose. She never needed more. She was 29 millicuries.
Another questions to Dr. Waralee. Thank you very much for visiting our country and delivering the very important topics. Regarding the thyroid nodule, it's very common in our country. I think it's also in your country as well. So the practice as in our country, the thyroid ultrasound, FNA, are not very much developed. And the patients, they're not knowing where to go, and they usually go to the surgery. And they end up with the thyroid surgery most of the time, with the biopsy become normal. So most of them are iodine deficient and multinodular goiter. The thyroid cancer is quite uncommon in these patients. So how is your experience in your country? Most of them, when you operate, they turn out to be cancer or turn out to be normal, suspicious nodule.
Actually, for my country, we do the ultrasound, and for right now, our radiologist is quite nice. They do the ultrasound and they try to tell us that which one should do the FNA, and if it very little, they won't do the FNA because we know that the small cancer, it will have low mortality rate. So if it's just only the suspicion and it's a huge one and we cannot molecular testing, we end up with a surgery too. But we will do, like now, we will discuss to the patients. Some patients, they can offer this expense, so we send the molecular testing outside the country and then we wait for the result. But normally, we will just end up with a surgery too.
Actually, I'm very interested about the molecular testing because I would like to share my experience about, I do have 2 thyroid nodules and then FNAC done for 2 times. One in Bangkok Hospital, and it shows only like a benign thyroid nodule. But my ultrasound every time is thyroid 2. And left side, I did a FNAC here. But I'm thinking, as you mentioned about the molecular testings, to know the exact pathology. So, but I found that what type of molecular testing you prefer to get the, like maybe correct, or what is the preference for the molecular testing? One question. Another question is the option of the ethanol injection. Actually, when I discussed in Bangkok Hospital, they tell me that ethanol injection, they don't recommend ethanol injection because it would make the nodule more difficult and then more like a fibrose. So I'm thinking, because I hope that my nodule will be just cystic benign, but I don't know what to do next for the confirmation not to get a malignancy in future.
Okay, thank you. For the first one, the molecular testing that we should use actually is the one that available. In Thailand, we available just only the thyroid print, which right now they have the company in Thailand, but for the rest like 𝗏𝗏 or 𝗏𝗏𝗃𝗖, we need to send it to Singapore actually, and then we get the result back. Yes, and for me, if I have the nodule with FNA benign, and normally I do the ultrasound because when we have the huge nodule, sometimes when we do the fine needle aspiration, it might not get the right sample. Yeah, so we do the ultrasound guide FNA quite often. So I think this might reduce the rate of benign and turn malignant after that. Yes. And for the second question, sorry, what it is?
Do you want to advise about the
ethanol
injection?
For the ethanol injection, I normally do just only the cystic, and actually it should be the cystic that more than 50%. Yes, we still do the percutaneous ethanol injections, but before doing that, for the solid nodule inside the cystic, we do at least 2 FNA to make sure that it's benign before proceed on the percutaneous ethanol injection.
Can I make a comment here? Actually, because it's interesting, you said that you send thyroxine over to Singapore. Actually, there's no need to do that. In danger, at risk of cutting down our business. If you go to the thyroxine is actually UPMC, so they are very happy to work with you and your institution, where you can actually send your slides to them. And you can do the same in Myanmar at the same time. You just go to UPMC website and discuss with them directly. Or you get to me, you can email me, I can give you the contact of the person, and then you can set up a line of communication. So all you need to do is your slide, 300 cells in each slide or one slide of that nodule. You fill up the form. They even have the courier for you, and you put it in, and then you send it. If they'll reach it quick, and by 1 or 2 weeks, you will get the result. But the initial setting up will be difficult. Yeah, it's a hassle, but then thereafter it'll be quite. The price though is a bit steep. So, well, yeah, so a few $1,000s, yeah.
Thank you.
May I ask one question, whether if I miss the thermal ablation for the malignant nodule, what is the cutoff size? And how sure about the cure rate on that thermal ablation?
Right now, it's preferred less than 2 cents. Okay. For the past, it recommended that less than 1 cent, but right now it's expand to 2 cents. Yes, but we need more data about this one, because for even the microcarcinoma, there's sometimes spread outside the thyroid. They have the lymph node metastasis. So we want to make sure that it's look benign and no metastasis of them all. Yeah.
So confirm by, how do you confirm that? No outside, just ultrasound or?
Just ultrasound,
yeah.
Just ultrasound.
Okay. Professor 𝗧𝗵𝘆𝗿𝗀 from Endocrinology.
Thank you, both speakers, for your very excellent talk. I want to ask Dr. Vivien about the hyperthyroidicosicosis, but the patient went to the severe reaction with the methimazole, so we can get to the severe neutropenia, so we can proceed to the antithyroid drugs. For that case, we plan to do the iron or surgery as quick as possible. We're trying to get lower down the thyroid function with the glucoiodine steroid and beta blocker. But we can get to the level of the safe level to proceed the IIN or surgery after 10 days of glucoiodine. For that case, what is your opinion and suggestion?
First of all, is it truly agranulocytosis because of thyrotoxic, because of the drug? Is one thing, because it really is rare. So that's the first question. Okay, so if it really is, yeah, we can't use the thyroid drugs unless you want to change over to the other drug with the risk that it will entail. Now, the second thing then is that it's either total it's thyroidectomy or radioactive iodine, again, depending on just like previous case, it depends on what contraindications does she have. Can she go for surgery? If she can do that, you beta block, you do that and you go, because it's never going to get better. So you have to go. You are beta blocked already. Your sympathetic outflow, everything is been blocked. All your effects of the thyroid, hopefully we are blocked. Then you have potassium iodide or glucose iodine. So that will decrease vascular diuresis. That will also help with the next one. And then you have your high dose of propranolol to give that, and steroid. And then you go with surgery. It's just like it's an emergency. If you have cardiac failure and all this, you need to get it out. You need to get it out. If there's appendicitis, you need to go. You need to go. So it depends on how urgent you are. And then you do that. I hope that answered the question.
Yeah. So you means we have to proceed with and we have to continue the steroid, beta blocker to get the level of the thyroid function to get to the IIN or surgery.
You might not get the thyroid function normalized, but you do not need a thyroid function normalized to go ahead and go. Because does it mean that you don't get it normalized, you are not going to go? You have to, right? Because so at the end of the day, it's an individualized approach. How urgent do we need it done? How much do we think that we can do? But if you keep on thinking about normality, what if we don't get normality? What does a level to be safe for surgery mean? Yeah, because any level, which is even TSH, which is depressed, subclinical, some anesthetists, if they're going for open heart surgery, wouldn't want that. You see? So what does safe level connote? So therefore, the discussion has to be patient, anesthetist, the head and neck surgeon, yeah, the hematologist and you, to decide when is the urgency, when you want to go. And if the decision is that if it's urgent enough, it doesn't matter what the thyroid level, you have blocked everything already. You need to go. The risk outweighs the benefits outweighs the risk. Go.
Thank you. So can we continue the glucoiodine more than 10 days, or how many days we can continue?
There's no point continuing more than 10 days because it works and then it gets away. So therefore, it escapes the Ewolff-Chaiko's reaction. It escapes from that inhibition. So if you give already, you better go within the first few days already. See what I'm saying, right? Yeah. And then that's it. And the steroid is only more for that theoretical benefit of T3, T4 conversion. And also because these are very thyrotoxic. I'm presuming very thyrotoxic patients, which may have relative adrenal deficiency. Relative, right? So I'm not giving them steroids for 10 days. No, I'm just going peri-operative if that's the case. Or peri-radioactive iodine. But in this case, sounds like something that I might want to go for surgery. Yeah, because radioactive iodine, you need to wait for it to work. And you don't know exactly where you are. So again, really depends on how urgent that situation. It's a tough case that needs to be sat down to discuss.
Thank you so much for your insight.
Any more questions from the audience? If no more, I would like to ask that last question then to Dr. Lilian. I've got a patient with a T3 thyroidosis with a huge goiter and very high TRAP. And the surgeon want to do the surgery, but whenever give their anti-thyroid drugs, medication, I change from carbimazole to PTU because of the T3 is very, very high. And when suppress, bring down the thyroid hormone, the T4 dropped to like a 0 point something, and T3 still high around 8 and 10. So in such case, what should we do? The surgeon reluctant with a very low T4 to do the surgery.
So in a normal thyroid, the predominant thyroid hormone which is being produced is T4. When it's no longer normal, sometimes it predominantly produces T3. Forget about the P, unless you are in a toxic situation. It's a theoretical benefit of PTU, inhibiting the conversion. Methimazole works very well. In fact, the data has shown that methimazole actually is better at the severe disease in outpatients. So actually, I will give methimazole 20 milligrams 2 times a day. I don't care what the free T4 shows, because the TSH, if the T3 is high, will be low. And if the TSH is low and the free T3 high, that is thyrotoxicosis. That is hyperthyroidism in this case, because it's Graves' disease. All right, so I wouldn't care about the T4. It's T3 which is predominant. So you give it as the same as any principle. You give that methimazole, you bring it down to normal, then off you go for the surgery. And in this case, you can even go for radioactive iodine. There's nothing to say that it has to be surgery.
Thank you. Any more questions? So with this last thyroid symposium, thank you to both speakers for very fruitful lectures and highlighting our insights and enhancing our insights. And I think every single the audience will satisfy with our last sessions. Thank you. So shall we end the session, close the session here, and I will hand over the session to the master of ceremony. Thank you, everybody.
Thank you.